So here we have a case of a two-level myelopathy, luckily not done by us. It was decompressed anteriorly, a cage and a plate was put. Now, post-operatively, the patient, probably intraoperatively, the surgeon suspected something, which probably meant that the esophagus was in danger. So next slide. So the patient had a sort of an esophageal tear. Now the primary surgeon has done an endoscopy there, and they could not really identify the tear, and that is why the Ryle's tube was kept for about 6 weeks post the post the cervical spine surgery. Can we go to the next slide? So after 6 weeks of surgery, the patient could tolerate the liquids well. There was a dysphagia for solids, and the patient could not cough out very well because the patient still had a very severe myelopathy. Next slide. So by about 12 weeks, the patient had neurologically improved to almost a functional status, and he was quite functional with that dysphagia still there. Next. So at 14 weeks, the patient suddenly developed a quadriplegia, and this was the MRI that we got. And as you can see, there is something happening around the inferior screws. There is an osteolysis, and there is a cuff which is encroaching on the spinal cord. So the first impression that we thought, this patient was a farmer. So the first impression that we thought that it is a pathological fracture, maybe an osteoporotic fracture which has given way. Next slide. So we had planned a revision surgery knowing fully well that this patient had an esophageal tear. So we had an ENT surgeon standby. The primary surgeon had gone from the right, we went from the left. Okay, and we dissected the whole thing, inspected the esophagus. Even the ENT surgeon cleared that there is no tear. The whole implant was loose. There was frank pus flowing out of the wound, and the patient had osteomyelitic bones right from C4 to C6, with the whole screws and the plate backing out, even the cages backing out. The culture that time was streptococcus. Next slide. So after we operated, we had put bone grafts instead of any kind of cage there. So we put iliac crest bone grafts and fixed this patient posteriorly with lateral mass screws. On day 3, the patient started spiking, very severe spikes, and the drain amount was about 100 cc's, which is quite abnormal, showing a white discharge with food particles in the drain pipe. Next. So we got our barium contrast done, and there was a leak, which was somewhere in the upper end. You can see that red arrow on the left. There was a leak pointing there. Luckily, we had not put any implant anteriorly this time. So what the plastics and the ENT guys told us is that you wash it and clear the infection first, and then wait for the infections to regress. So the culture this time was Pseudomonas. So next slide. So this was, you will have to play the video, Chandan. Play the video right from the middle. Play it in the middle. Yeah, play from the middle somewhere. Yeah. So this is how the sort of saliva was getting discharged, and the aim was to achieve a control of infection and to narrow down his hematological parameters, develop a cutaneous fistula. So this is what was achieved by about 3rd week. Next slide. Next, go next. Next slide. So then the plastics took over. They repaired the esophagus and reconstructed it with a sternocleidomastoid flap. So this was the patient 3 weeks after this surgery. Next. So you'll have, and luckily, even after all this, you'll have to play the video. So the patient was a grade 0 with a pyogenic osteomyelitis, and this is at 3 months post surgery, where his upper limbs have recovered functionally. His esophagus is normal. and he's able to tolerate liquids and solids well. So the lessons that probably we've learned from this is that when you're dealing with any kind of cervical anterior spine surgery, you have to remember that it is an anterior approach, and it is not the spine surgery that is technically difficult, but you have to be very careful of the viscera, because viscera are unforgiving. So you can have lots of damages anteriorly. Next slide. So when you are dealing with these kind of situations, now this is one of our own cases where we have done a 2-level anterior plate. Everything was hunky-dory. The patient did very well, and the plate backed out in 3 months' time, and we do not know the reason. So whenever you are doing an anterior plate, one has to be very, very careful. You have to remember that longer the fusions, longer are the problems. So if you don't size your plate well, there will always be a certain amount of subsidence, plate migrations. There would be anterior segment diseases, plate backouts, plate failures, no matter what kind of grafts you're using. So if you're doing more than 2 levels of fusion, always try to flip the patient over and do a posterior fusion. Next slide. So even if you are planning to use a standalone cage, which is probably one of the easiest implants to be used nowadays, either you use it with a screw or you use it without a screw. But you have to remember that the conditions are not the simplicity of the implant, but the conditions of the end plates. So don't oversize your cage, because there's always going to be a back pressure from the end plate. And in osteoporotic bone, it means a certain degree of subsidence. Now we know that subsidence is okay so long as we have achieved a fusion. But look at this patient now. Turn next slide. So this patient sort of healed with a certain degree of kyphosis and developed an adjacent segment disease over a period of time. This is 8 years from the index surgery, where he developed a C5-6 and a C7D1 at the same time. And we had to revise it to decompress and get a good result. Now, this was a lower sort of cervical spine surgery, and the patient had a hoarseness for about 3 months, which added to his woes. So next slide. So be very careful when you are doing an anterior approach. You can have previous platings like this with an adjacent segment. Now, probably one of the recommended things is an anterior disc replacement. This is probably the only experience I have of an anterior disc replacement following a plate. I don't know what's going to happen, but this patient survived for about 5 years, after which there was a spontaneous fusion, and it became a very expensive cage for the patient in the end after 5 years. Next slide. So now one of the most important things in cervical spine is, no matter how flexible the column and no matter how confident you are about your MRI, always get a CT scan done, because you will be surprised of new ossifications around the posterior edge of the bodies, which are going to change your entire approach when you are trying to do a surgery. So CT scan is not a luxury, it is an adjunct to your MRI. And whenever you are in a slightest amount of doubt, always get a CT scan done. Next slide. You'll have to play the middle video. So this surgeon found out in a very bad way that he has not studied his CT scan, and he got an anterior cervical esophageal leak. The leak unfortunately did not remain contained. It spread into the soft tissues. The patient developed an obstruction to the airway and had to be ventilated. Then we had to intervene, and then we had to seal the leak with your Duragen and your TCLs and everything inside. We sealed the leak. Luckily, the cord picked up. The patient had developed a quadriplegia, and the cord picked up eventually, and eventually the patient did well. So next slide. So this is a typical example of probably where we go wrong in selection of our approach. Now, this is an elderly patient with a hard disk, osteophytes going across the body, and a foraminal stenosis. A posterior endoscopic surgery was done for him. They probably could not relieve the compression. So an anterior endoscopic surgery was done at the same time. And the patient's complaint still persisted. The patient developed a dysphagia post-op. And when we opened him up with an ENT guy, there was a severe fibrosis around the wall of the esophagus, and luckily there was not a through and through puncture, but this patient had a torrid time to come out of it. So when you are selecting a procedure, you have to sort of, like Chandan said, it is not one shoe that fits all. You have to be very, very careful when you select your procedures for every patient. Next slide. So now this is a young elderly patient who was selected for a transarticular screw. Only the lateral X-ray in the middle seems to be a good chunk of the fragment. But if you see the first picture, there is a significant degree of osteolysis extending into the facets. Now, odontoid screw was put. It looked very good for about 6 months, after which the odontoid screw failed, and it's a terrible mess trying to remove an odontoid screw. So one has to be very, very careful when you are selecting a patient, and it has to be a young, good quality bone, which is hardly multi-fragmented. So it should be two pieces which are trying to gel together. That's a perfect indication for your odontoid screw. And don't enter into situations where you have to revise it. Next slide. So now this is a case of an sort of atlantoaxial dislocation, a congenital variety with ankylosing spondylitis on top. So a long segment construct was put. Now, if you see the liver arm for this kind of construct, it's just too long. And if you have not achieved a good fusion, next slide, the whole implant gave way because it could not contain the forces on the C1, C2. And there was a recurrence of basilar invagination and a significant deterioration of neurology. So next slide. So this was a typical example where you needed to really plan out the surgery in detail, and you had bad lateral masses of the C1, completely dysplastic C2, high riding vertebral arteries. So in this case, trying to get closer and closer to your apex of the deformity was a challenge. So working on Dr. Gawhale's principle. Next. So an osteotomy through the C1, C2 was planned, and we had to use navigation as well as mesonic saws to prevent sort of injuries to the viscera. And we had to fashion an osteotomy. In passing the C1 screw, ultimately the osteotomy entered into the C1 screw. The C1 screw had to be backed off. So the final fixation was not a complete reduction, but enough space for the cord to recover. And we ended up achieving a sort of a functional result for the patient. Next. So whenever you think of doing a C1, C2 joint, I think all of us have only one structure in mind, that is the vertebral artery. So all your fixations are decided by this one structure called as a vertebral artery. And you have to really, really understand the anatomy well before you go in for any kind of screw in the C1, C2 junction. So because the space for the cord and everything is optimal, but that vertebral artery is unforgiving. Next. So I think these are videos. Can you click on it? Click, keep clicking. So when you have an adequate pass, keep clicking on it. So when you have an adequate pass, it is very easy. But when you have a sort of a high riding vertebral artery, it is not only the high riding, but it is also the medially encroaching. So what you can't see is how much is the narrowing on your mediolateral diameter. And this is where you can actually go wrong, putting a screw across the pars into the C1. So you have to be very, very wary of all these things. And I think Chandan has already pointed out the next slide. Next slide. So he's already discussed this, what you do when you have a rupture. Avoid putting a screw. Put a screw on the non-dominant side first. When fixed with a bleed, don't try to put in a screw blindly because it may go anywhere. And you have to just tamponade it, finish the fixation, and get the help of an interventional radiologist, and don't try to screw a bleeding vertebral artery. Okay, next slide. So whenever you do a laminectomy, be sure that there will be some amount of kyphosis which will come over a period of time. But as people say, it is not a bad progressive kyphosis that follows a laminectomy in an elderly, and the back shift principle works over a period of time, and all elderly patients are going to stoop a little. So don't think that kyphosis is an abnormal thing after a laminectomy. Next slide. But you have to be very careful when you're doing a laminectomy that you don't destroy your facets. Otherwise, you will end up with a segmental instability. And that instability will ultimately cause myelopathy. So you have to be very careful of your facet joints. Next slide. So whenever you're taking any X-ray, like in the lumbar spine also, in the cervical spine, be sure that you take your flexion extension views, because there are cases rarely where you have a seemingly good lordotic spine that can slip when you are taking a flexion X-ray, and you may not end up selecting the best procedure for this patient. So you have to be careful in detecting your instabilities in the lumbar spine also. Next slide. Deltoid palsy is a reality. That means laminectomy and lateral mass fixations are very, very good procedures. But more than the laminectomy, patients who have laminectomy and lateral mass fixations have higher incidences of deltoid palsy. So you have to warn the patient pre-op, and there are no clear-cut guidelines as to how to manage deltoid palsy. Now, if you have a pressing pathology, that means you have a wrongly put screw or a very, very stenotic foramen, you may intervene again and try to release it. But most of the times it is a conservative approach, and about 70% of these deltoid palsies recover, but it may take a very long time. It may take up to 6 months, 8 months. Sometimes there are delayed recoveries even up to a year. Next slide. So it is not very clear that whether anterior procedures have lesser incidences of deltoid palsies, and a fair amount of deltoid palsies have been noticed even with anterior procedures for cervical kyphosis. Next slide. This is my last one. The most progressive cervical kyphosis are the ones which are done for tumors in early childhood days, or where you have really destroyed your bony masses and allowed the deformity to progress over a period of time. These are malignant kyphosis, and these are not something which you see after a standard laminectomy. So whenever you are faced with such a situation, it is all about planning, and you may require anterior, posterior, anterior approaches. And it is very, very important that you plan and explain to the patient that you may have multiple problems even after the surgery, and you have to be extremely lucky to get out of these situations. So thank you.